Assalamu alaikum. We are pharmacy students from Al-Mashriq University. I am Reem Hamdan with my friends Rand Mehdi Khawam, Binan Amr, Ra Abdel Menam, Khalid Walid Faraj. We talk about blood pressure management of hypertensive emergencies. This is a screenshot of the study. Introduction. First, we need to know what is hypertensive emergency. This educational review proposed the BARKH-based algorithm which helps a fast and easy method of identification of hypertensive emergencies and acute organ damage. A task force of the European Society Cardiology recently proposed that the terms hypertensive crisis and hypertensive urgencies, being misleading and useless, should be abandoned and attention should be focused on recognizing the patient presenting with hypertensive emergencies. Therefore, they conceived this mini-review as educational paper to provide helpful information on proper terminology, basic pathophysiology, and the treatment of hypertensive patients. Definition and epidemiology of hypertensive emergencies. Hypertensive emergencies is where patients present with high blood pressure which imposes a threat to organs and may cause organ damage and death, such as organs, brain, arteries, retina, kidney, and heart. And this is where the BARKH-based algorithm comes from. This table explains the BARKH-based algorithm for identifying and managing hypertensive emergencies. It starts by detecting severe hypertensive and checks for organ damage in key areas such as the brain, heart, kidneys, and arteries. If organ damage is confirmed, it's classified as hypertensive emergency requiring immediate blood pressure reduction. The algorithm then guides the selection of specific antihypertensive drugs tailored to the affected organ, ensuring effective and safe management. This approach simplifies decision making in emergency cases of severe hypertension. The choice of antihypertensive agents and does depend on the organ damage and the presence of contraindication.
Assalamu alaikum. I am a student Rand Mehdi. I will continue the seminar. Pathophysiological consideration and implication for management. One of the main problems with hypertensive emergency is loss of autoregulation, which is the perfusion of blood between the organ and the blood vessel. When autoregulation is lost because an increased blood pressure, the balance of perfusion leans toward organ and tissue, which cause edema, and it may be fatal in cause of cerebral edema and cause organ damage. The speed and severity of blood pressure elevation are the main driving factor of hypertensive emergency. A rapid increase in blood pressure activates the renin-angiotensin system, which in turn raises the peripheral vascular resistance in the kidney and other vital organs and changes the autoregulation. In turn, renin-angiotensin system activation causes oxidative stress by formation of peroxynitrite, which increases impairment of nitric oxide bioactivity. It causes endothelial dysfunction and damage. The dislodging of endothelial cell and exposure of subendothelial tissue to blood lead to activation of platelet aggregation and the clotting start. In the slide are talking about mechanisms that lead to loss, autoregulation, and injury to microcirculation in severe uncontrolled hypertension. In case severe uncontrolled hypertension, the renin-angiotensin system is activation and lead to series of events. Increased renal vascular resistance, induced natriuresis, autoregulation failure because the renin-angiotensin system is activation, and microvascular damage, endothelial disruption, subendothelial tissue exposure, activation of platelet and clotting cascade, thrombocytopenia, and thrombotic microangiopathy, especially in the organ, brain, arteries, retina, kidney, heart. In this slide, I will talk about the complication of uncontrolled hypertensive, and the most dangerous complication is hypertensive encephalopathy. Occur when an increase of blood pressure value exceeding the upper of the autoregulatory range can raise the intracranial pressure, leading to cerebral edema, especially in posterior area. Um, Hypertensive encephalopathy can cause posterior reversible leukoencephalopathy syndrome, a condition featuring headache, vision abnormalities, nausea, altered mental state, white matter lesion, and vasogenic edema in posterior brain region. If left untreated, hypertensive encephalopathy and posterior reversible leukoencephalopathy syndrome can progress to cerebral hemorrhage, coma, and death. Thrombotic micro um, Thrombotic microangiopathy, endothelial damage occurring in hypertensive emergency, trigger a cascade of events that begins with platelet activation and thrombi formation, microvasal obliteration, disseminated intravascular coagulation, and progressing to thrombotic microangiopathy.
Assalamu alaikum. My name's Roa Abdul Mun'im. I am talk about preeclampsia. So, it is one of the main components of high blood pressure that can occur during pregnancy, so-called gestational hypertension. So, edema is not considered as a criterion of preeclampsia because it occurs in up to 16% of the normal pregnancy. Preeclampsia develop in 5 to 7% of a pregnancy with a 3 to 5-fold higher rate in women with already existing hypertension, and even more commonly in first pregnant diabetic multiple fetus. So, to prevent hypertensive complication in the mother, blood pressure should be reduced to 60 per 10 500 millimeter mercury with IV labetalol or nicardipine along with magnesium sulfate for prevention of seizure and convulsion. So, with labetalol, must be monitoring of vital heart rate is needed to avoid bradycardia and its cumulative daily dose should not exceed 1800 milligram. When switched to oral treatment, example methyldopa and long-acting nifedipine are the first choice. ACE inhibitor and angiotensin receptor blockers should be avoided because of potential teratogenicity. Diuretics are not recommended because they reduce amniotic fluid and placental blood flow. So, number 4, acute coronary syndrome. Administration IV nitroglycerin and lowering systolic blood pressure to less than 14 millimeter mercury, considering that this patient usually receive antiplatelet drugs such as aspirin, ticagrelor, ticagrelor and clopidogrel that raise the risk of cerebral hemorrhage. The lowering of high blood pressure is an obligatory step. Beta blocker should be used to lower cardiac work and myocardial oxygen consumption and to control nitroglycerin induced reflex tachycardia. If they are contraindication, a non-dihydropyridine calcium channel blockers as verapamil or diltiazem represent reasonable alternative.
Assalamu alaikum, I'm student Benan Amr. I'm going to continue the lecture. So, acute heart failure. The goal is lowering afterload, thus improving the ejection fraction and resolving lung congestion. Hence, IV loop diuretics along with nitroglycine up titrated to the highest tolerated dose to decrease afterload and preload. The mineral corticoid receptor antagonists can be effectively combined with loop diuretics as they help prevent hypokalemia. Time is life. With the help of Barca-based algorithm, we can quickly understand the patient's situation and give the best available treatments using Figure 5. So Figure 5 will help us quickly understand the Barca-based algorithm and what it means by that. So Barca means brain, artery, retina, kidney, and heart. Each one have the first letter of which make Barca. So we're gonna start with the brain. So in the brain, we're gonna look for any neurological symptoms, something like the inability to speak properly, the inability to understand other people's speech, and the inability to control one's muscle. If yes, we're gonna use the CT scan to identify any encephalopathy or stroke. If there is, maybe there's a hemorrhage stroke. So if there's a hemorrhage stroke, we're gonna consider IV drugs, and with the help of IV drugs, we're gonna look for a systolic blood pressure of 180 to 130. And if nothing works, we're gonna consider surgery. Then, if there's nothing with the brain, we're gonna go for the arteries. We're gonna look for a chest pain. Why chest pain? Because there's two major arteries in the chest area. One is aorta and the other is coronary artery. Both is located around the chest area. So, using ECG and imaging, we're gonna look for any damage in the aorta or coronary artery and see if there is any acute coronary artery syndrome. If yes, we're gonna consider IV drugs, and the systolic blood pressure will be 120. If we are done with the arteries, we're gonna look for the retina, see anything wrong with it. By that, we look for headache, visual impairment, headache by around the head, around the forehead, around the eyes, and visual impairment by blurry vision or double vision. So if there is any, gonna use fundoscopy to search for grade 3 or grade 4 retinopathy blood brain CT. If yes, then there is a possibility of ischemic stroke. If yes, there's a ischemic stroke, then we're gonna use IV drugs. The goal is mean artery pressure on minus 15, gonna lower it by 15%, or systolic blood pressure by 180, less than 180. When we are done with the retina, we're gonna look at the kidney. We're gonna look for any acute kidney insufficiency. If there is, then we're gonna use LDH and platelet count to search for any microangiopathy. If there is, then there is a possibility of thrombotic microangiopathy. And if yes, you're gonna use IV drugs, and we're gonna need to lower the mean arterial pressure by 20 to 25%. Heart. Next is gonna be the heart. Heart failure or acute coronary syndrome both can cause damage to the heart. If there is any one of them, consider IV drugs or oral therapeutical therapy, and plan a follow-up after that every 2 to 3 months. So the blood pressure goal is lower than 180, or mean arterial pressure by 25%.
For management of hypertensive emergencies, the pathophysiological and autoregulation of blood flow in the vital organs are important. Initiation of an IV treatment to achieve a rapid blood pressure reduction is mandatory. But in patients who do not have a hypertensive emergency at BARKH assessment, administration of drugs that lower blood pressure acutely is contraindicated. One of the best drugs was labetalol, which proved to be an effective all-round agent, well tolerated and with few contraindications. When given intravenously, it has alpha-blocking activity, which is useful in most hypertensive emergencies. Labetalol effect occurs within 2 to 5 minutes and peaks over 5 to 15 minutes. A 20 mg IV bolus is usually followed by continuous infusion, the rate of which can be up or down titrated to reach and maintain the desired blood pressure target values. In the patients with hypertensive encephalopathy or stroke, labetalol should be preferred to nitrates, such as nitroglycerin and nitroprusside, because it leaves the cerebral blood flow unaffected and does not increase intracranial pressure. As for treatment of hypertensive emergencies, if the patients are candidates to emergency reperfusion therapy with IV alteplase, because this is feasible only if their blood pressure is not severely elevated and fear of hemorrhage. Some of the first-line alternative treatments for hypertensive emergencies are labetalol, and the alternative being nitroprusside, nicardipine, where the alternative being orabitil. Labetalol also has another alternative, nitroprusside, depending on their blood pressure. Hypertensive emergencies caused by cocaine abuse are becoming more common. They can present with chest pain, tachycardia, altered mental status, cerebral hemorrhage, seizures, arrhythmias, and even sudden cardiac death. Diluted pupils is a major sign of hyperadrenergic state that is associated with cocaine abuse. Hypertension secondary to cocaine is responsive to IV benzodiazepines that minimize the stimulant effects of cocaine on the central nervous system, and to mixed beta and alpha blocker labetalol. Nitroglycerin or nitroprusside can also be administered if further therapy is indicated for chest pain. Non-selective beta blockers are contraindicated because of the risk of an abrupt rise in blood pressure, as well as coronary vasoconstriction due to the exaggerated effect of catecholamines on unblocked alpha receptors. The vast majority of patients presenting at the emergency department with high blood pressure values do not have a hypertensive emergency and do not need acute blood pressure lowering, but rather referral to a hypertensive specialist or center for proper workup aimed at discovering the underlying cause. Rapid blood pressure lowering may cause more harm than good because of hypoperfusion. BARKH-based algorithm for quick identification and treatment of patients with hypertensive emergencies. As for comments and critique, it seems hypertensive emergencies to be higher in developing countries, example Iraq, and that is why we choose this article. The BARKH-based algorithm is very efficient in helping us diagnose the patient's situation. Didn't know labetalol was this effective and an all-around drug for almost any hypertensive emergency.